Your forehead isn't the problem. That's the sentence I keep coming back to. Every week, someone asks me whether they should try a cosmetic procedure for the lines on their forehead. Some of them have already tried something. Some are still deciding. And every time, I find myself looking past the forehead, past the skin, past the muscle, at something that sits 2 feet lower and nobody's discussing: the spine. Specifically, 4 vertebrae in the upper thoracic spine, T1 through T4. 4 bones that, when they drift into forward flexion, which they do in almost every adult over 50, and in a lot of people much younger than that, change the resting position of everything above them, including the skull, including, by extension, the face, including the forehead. Thomas Myers spent decades mapping what he called the superficial backline, a continuous sheet of myofascial tissue that runs without interruption from the soles of your feet, up the back of your legs, up the spine, across the base of your skull, over the top of your head, and down to the frontalis, the flat muscle that sits across your forehead. One line, one continuous structure. Not a metaphor, not a conceptual framework, actual tissue you could follow with your hands. I want to be precise about what this means for the next 30 minutes. Your forehead is not free-floating. It is the terminal end of a fascial highway that begins in your feet and passes through your thoracic spine on the way up. When something changes in the middle of that highway, specifically at T1 through T4, the end of the highway feels it, and you see it in the mirror every morning. So before we talk about what happens at the spine, before we go through the technique, I want to walk through exactly why the assumptions most people carry about forehead aging are structurally incomplete. Not wrong about everything, incomplete. There's a difference, and it matters. Because understanding the incompleteness is what allows you to see the solution. Let's start with the simplest one. You've lived in this face your whole life. You've watched it change. And at some point, maybe in your 40s, maybe your 50s, you started noticing the forehead differently. Horizontal lines that weren't there before. A quality of the brow that suggested something had moved, settled, shifted. And the natural conclusion was, this is what skin does over time. This is what muscles do when decades of expression accumulate. The face is aging. That conclusion is partially correct. The skin does change over time. Collagen remodeling is real. Sun exposure matters. The orbicularis oculi weakens. These are facts, but they are facts about a different phenomenon than the one we're examining today. The phenomenon today is this: why does your forehead look different after 8 hours at a computer than it did in the morning? Why does the brow position change across a single day, not across a decade? Why do certain people who address nothing but their spinal posture report changes in their forehead's resting appearance that no surface treatment was producing? Skin doesn't age in 8 hours. Collagen doesn't remodel in a workday. What changes in 8 hours is position. And position is a mechanical phenomenon, not a biological one. The biology matters for certain things. The mechanics govern others. The frontalis muscle, the one that creates horizontal forehead lines, has an unusual anatomy. Most skeletal muscles attach at both ends to bone. Origin on one bone, insertion on another. Contraction moves one bone relative to the other. The frontalis doesn't work that way. It attaches superiorly to the epicranial fascia, the dense sheet of connective tissue across the top of the skull, and inferiorly to the soft tissue of the brow, including the skin itself. There's no inferior bony attachment. It pulls upward on the brow tissue directly. Now, the frontalis contracts to elevate the brow. That's its job. Brow elevation for facial expression, yes, but more fundamentally, brow elevation to maintain horizontal gaze when the head tilts downward. When your skull tilts forward, when you're at a screen, when you're driving, when you're looking at a phone, the frontalis contracts to bring your brow back up so you can see straight ahead without tilting your entire neck further back. This is not a problem in the short term. Muscles contract, that's what they do. The problem is what happens when the skull's forward tilt is not a temporary event, but a structural baseline. When the head lives slightly forward of where it should be, not because you're concentrating on something in the moment, but because the architecture underneath it has allowed it to drift there permanently. That's assumption one. The face is the site of the problem. It isn't. The face is the site of the symptom. Dr. Carla Stecco's dissection work at the University of Padua changed what anatomists understood about fascial continuity. Her lab's approach, examining whole fascial sheets rather than cutting through them to isolate individual muscles, revealed connections that segmental dissection had systematically missed for a century. The sheets don't stop at the arbitrary boundaries that human dissectors drew for convenience. They continue. They communicate. They transmit force across regions that classical anatomy had categorized as separate. Which brings us to assumption two. Most people who are aware of posture's effects on the body apply that awareness to the back, the shoulders, the neck, maybe the jaw. They understand vaguely that slouching isn't great. What they have not connected is the pathway from posture to face. From the thoracic spine, specifically T1 through T4, the uppermost thoracic vertebrae, the ones that sit just below the C7, the prominent bone you can feel at the base of your neck, to the muscles and fascia of the forehead. The pathway exists. Myers mapped it. Stecco's lab confirmed the tissue continuity that makes it mechanically real. And here's what it means structurally. The cervical spine, your neck, is not a freestanding structure. It is a column sitting on top of the thoracic spine. The thoracic spine provides its base. When T1 through T4 flex forward, when that segment drifts into the kyphotic curve that screen culture has made almost universal, the cervical spine's base is tilted anteriorly, forward. The cervical spine compensates, usually by developing an exaggerated lordotic curve of its own in an attempt to bring the eyes level. The skull rides on top of that compensated curve. The net result? The skull sits forward of where it would sit if T1 to T4 were in a neutral or mildly extended position. Not dramatically. We're not talking about the posture of someone with severe pathological kyphosis. We're talking about the subtle, cumulative, almost invisible forward drift that develops in people who sit at desks, drive cars, and use phones for years on end without ever deliberately reversing the direction. Subtle drift. Real mechanical consequence. The head weighs approximately 10 to 12 pounds. For every inch of forward displacement from the neutral plumb line, ear over shoulder, shoulder over hip, the effective load experienced by the cervical and upper thoracic structures increases by approximately 10 pounds. This is not a theoretical estimate. It comes from surgical and biomechanical research in cervical spine loading. At 2 inches of forward head carriage, you're managing 20 extra pounds of effective load. At 3 inches, which is common in people who have been working at screens for a decade or more, you're at 30 additional pounds. The postural muscles of the upper thoracic region, the rhomboids, the lower trapezius, the thoracic erectors, are fighting that load constantly. And slowly, incrementally, they lose ground. Let me put a specific face to this. A person in their late 50s. They were told their forehead lines were the result of decades of expression, smiling, frowning, squinting in sunlight, which is true. But they were also told that's all that was driving it. In the morning, after sleep, their forehead looked different than it did after a day of working at their desk. Not dramatically different, but the brow sat differently. The resting position changed across the day. And no topical treatment, no matter how consistent, touched that component. The one that was mechanical, the one that belonged to the spine. Now we've taken apart two assumptions. The face as the source, posture as irrelevant to the face. What remains, what the anatomy actually shows when you follow the tissue, is a mechanism that no injectable has ever been designed to address, because no injectable lives in the thoracic spine. Here's the mechanism in full. The superficial backline, as Myers mapped it, runs from the plantar fascia at the sole of the foot, up the gastrocnemius and hamstrings, through the sacrotuberous ligament, up the erector spinae along both sides of the spine, across the posterior skull at the suboccipital region, over the epicranial fascia, and down to the frontalis. When T1 to T4 flex forward, when that segment folds into kyphosis, two things happen to the posterior portion of that chain. First, the thoracic erectors in that region are forced into a lengthened, eccentrically loaded position. They're not shortening. They're being stretched and asked to hold at a length that isn't their functional home. Second, and this is the part that reaches the face, the suboccipital muscles, the small, precise muscles that connect the base of the skull to the top of the cervical spine, are placed under altered tension as the skull migrates forward. The occipital ridge, the bony attachment site for the suboccipital muscles, in the point where the superficial back line connects skull to spine, shifts anteriorly. That shift transmits through the epicranial fascia. In the frontalis, sitting at the end of that chain, has to work harder to maintain brow elevation against a changed baseline. Not because it's been asked to express anything, because the scaffolding underneath it has moved. The word I keep reaching for here is not affect, it's load. The thoracic change loads the frontalis differently than it would be loaded in a neutral posture. Encrotic loading over months and years is what produces chronic tension lines. Now, I want to be precise about what the technique does and doesn't do. Before we get into the position itself, actually, let me back up, because the most important part of this is finding the right location on the spine. And if you rush past it, the technique changes entirely. C7, that's your landmark. Stand or sit upright and tilt your head slightly forward. Run your fingers down the back of your neck. At the base, where the neck meets the upper back, you'll feel a prominent bony bump. That's C7, the 7th cervical vertebra, the most prominent spinous process in most people. Everything below C7 is thoracic. T1 is immediately below it. T2, T3, T4 follow in sequence moving downward, each approximately 2 centimeters apart in an adult spine. The target zone for the technique, the area where the towel or the firm support will contact your spine, is 1 full hand width below C7. This places you roughly at T2 to T4. That's the thoracic apex in the majority of people with upper thoracic kyphosis. It's where the forward curvature is most concentrated. It's where extension will produce the greatest change in the cervical spine's resting position. Now, the technique itself. Context matters here, and I want to be direct about that. If you have a diagnosis of osteoporosis, if you've had any vertebral fracture, if you've had recent thoracic or cervical spine surgery, or if you have any condition affecting bone density or structural integrity in the spine, this technique is not appropriate without direct guidance from your physician or physiotherapist. Extending the thoracic spine over a firm support produces real force. In healthy bone, that force is therapeutic. In compromised bone, it requires clinical supervision. That's not a disclaimer I'm adding for legal reasons. It's a structural fact about how extension mobilization works. For everyone else, and this is the majority of people watching this, the technique is straightforward. You'll need a rolled towel or a firm yoga block. A yoga block is ideal because the height is consistent. A rolled bath towel, rolled firmly to approximately 3 to 4 inches in diameter, works. A foam roller is generally too soft to produce the sustained extension needed. It compresses too much under body weight. Lie on your back on a firm surface. A carpet or yoga mat is fine, not a soft mattress. Place your support, towel or block, horizontally across your spine at T2 to T4, using the C7 landmark and the 1 hand width measurement to position it correctly. Let your arms rest at your sides or cross them over your chest. Do not use your arms to push or support your weight. The technique works through gravity alone. Now simply let the weight of your body do the work. Your thoracic spine, the segment above the support, will begin to drape into extension over the support. You will feel a stretch across the anterior chest. You may feel a mild ache in the upper back muscles as they lengthen. You may hear or feel clicking from the thoracic joints. All of this is normal. What is not normal? Sharp, localized pain at any single point in the spine. Radiating pain down the arms. Numbness or tingling anywhere. If you experience any of those, stop immediately. Come out of the position slowly, rolling to your side first, and consult with a clinician before trying again. Stay in this position for 90 seconds. Set a timer. Don't approximate. 90 seconds of sustained posterior pressure is long enough for the viscoelastic properties of the thoracic fascia to begin responding. Shorter durations produce less change. Longer durations, up to 3 minutes, can be appropriate for people who have been doing this for several weeks and want to progress the technique. When you come out, roll to your side first. Come up slowly. Sit at the edge of whatever surface you're using for 15 to 30 seconds before standing. Some people feel briefly lightheaded as the nervous system recalibrates to the changed spinal position. Do this once daily. Morning is ideal, before you've accumulated hours of anterior load from the day's activities, before screens, before the desk, before the commute. Evening is a meaningful second choice as a deliberate reversal of the anterior load accumulated across the day. Either is beneficial, both if you want to accelerate the process. What should you look for? The changes are postural before they're cosmetic. In the first week, most people notice that their upper back feels less compressed late in the day. Some notice a change in how their jaw and neck feel. The release at T1 to T4 often has an immediate influence on cervical mobility. By 2 to 3 weeks of daily practice, some people begin to notice a change in their resting forehead position. Not a dramatic change, a subtle one. The brow sits slightly higher at rest. The horizontal lines are present when the frontalis contracts, as they should be, but their resting depth, the depth when the face is at complete rest, has changed. Because the mechanical input to the frontalis has changed, this is what the injectable doesn't touch. This is the component of forehead presentation that belongs to the spine, not to the skin. The injectable relaxes the muscle. This changes the load the muscle is carrying. They are different interventions for different parts of the same phenomenon. A 2022 analysis examining outcomes in patients who combined cervical and thoracic postural correction with cosmetic facial procedures found that the postural component produced independent, measurable changes in eyebrow resting position as assessed by standardized photography. Changes that were not replicated in the group receiving cosmetic procedures alone. The postural effect was slower in onset. It was also more structural, and it addressed a component that the procedures, by their mechanism of action, simply couldn't reach. You've just watched that mechanism work. The demonstration happened in the reasoning itself. You followed the anatomy from the thoracic spine to the frontalis. You saw where the load comes from. You have the technique, the landmark, the duration, the position. The next step isn't cognitive, it's this. Tonight, or tomorrow morning, roll a towel, find C7, measure 1 hand width, and lie down. 90 seconds. That's the entire ask. Your forehead and your spine are the same structure. They always were. Understanding that changes what you look for, what you address, and what you can actually shift in a way that starts tonight, not after a waiting room and a recovery week. There will be more about the fascia, about what else runs along that line, about what changes and what doesn't. And if the anatomy we covered today is the kind of thinking you want more of, subscribing means you won't have to find your way back. The spine, 2 feet below the problem you've been staring at, the place where the real conversation begins.